Hi, this is Tricia Hannick, the Director of Quality Improvement with the HSHS ACO and Physician Clinical Integration Network. Today I'm going to talk to you about the disease-based clinical quality metrics in 2017. As a disclaimer, Medicare has neither reviewed nor endorsed this information. The first measure, and it actually has two measures underneath of the diabetic composite measures. This is an at-risk population or diabetic domain. It is a reporting year only for 2017, meaning we aren't held to a specific threshold. We just have to show that we can report it accurately and completely. The first portion of the diabetic measure is ACO 41, which is a diabetic eye exam. This is for patients who are aged 18 to 75 who have type 1 or type 2 diabetes. To meet this measure, they have to have had a retinal or dilated eye exam by an optometrist or ophthalmologist during the measurement period, or a negative retinal exam which showed no evidence of retinopathy in the prior 24 months. This is the patient-reported requirement is if the patient tells you the date, even just the year, and the results of the test, that will be acceptable by CMS for this measure. Also, the documentation of the diabetic retinal disease screening can be completed during a telehealth encounter. The second part of the diabetic composite measure is ACO 27, diabetics with a hemoglobin A1C in poor control, which is defined as greater than 9% on their hemoglobin A1C. This is also a at-risk population or diabetic domain, and it will be a reporting measure only for 2017. Just as the other diabetic measure was, these are patients 18 to 75 with type 1 or type 2 diabetes who have had a hemoglobin A1C greater than 9 during the measurement period. The measurement period is January 1st of 2017 through December 31st of 2017. This is an inverse measure, meaning the lower the score, the better, because as you can see, it's those patients who are in poor control, and we want our patients to be in good control. So the lower the score, the better. As far as patient reported, they can actually tell you the date and year and the most recent value, but it must be a distinct value. So it has to be an 8.0 or whatever the score is. They can't say normal or abnormal. And then this would have to be documented in the EMR so that we could show CMS that it was in there. Again, documentation in the EMR must include the date of the hemoglobin A1C test and the results. Documentation of the most recent hemoglobin A1C result can be completed during a telehealth encounter. The next measure, ACO 28, is controlling high blood pressure. This is part of the at-risk population domain. This will be a pay-for-performance measure for 2017. So we will at least have to get 30% of the national benchmark as our score to be able to share in savings. So this is for patients age 18 to 85 who have a diagnosis of essential hypertension within the first 6 months of the measurement period, so January to June 2017 or any time prior. To be positive in the numerator, the blood pressure at the most recent visit during the measurement period must show that the blood pressure is adequately controlled, as defined as less than 140/90. If multiple blood pressure readings are found in the most recent encounter, you are able to use the lowest systolic and the lowest diastolic reading as the most recent blood pressure. Exclusions to this measure include patients with evidence of end-stage renal disease, dialysis, or renal transplant, or pregnancy. The last measure I'm going to discuss is ACO 30, ischemic vascular disease, who use aspirin or another antithrombotic. This is also part of the at-risk domain. It is a pay-for-performance measure for 2017. This includes patients who are 18 and older who were discharged alive for an acute myocardial infarction, a CABG, or a percutaneous coronary intervention in the last 12 months prior to the measurement period, so in 2016, or who have an active diagnosis of ischemic vascular disease during the measurement period, which is 2017. To be positive or be in the numerator, they have to have a documented use of aspirin or other antiplatelets during the measurement period. And CMS did get more specific in outlining what medications will be considered compliant with this measure. So you have aspirin, Plavix, and the others listed there on the screen. The diagnosis of peripheral vascular disease or peripheral arterial disease will not be considered confirmation for the IVD diagnosis this year. Exclusions to this measure include documented use of anticoagulants such as Coumadin, warfarin, Lovenox, heparin, and all of those listed on this screen. And that concludes my presentation on this. If you have any questions, please feel free to reach out to me, Tricia Hannock, and my phone number is 217-757-3164. Thank you.